We will be tackling on diagnostic evaluation of diabetic retinopathy and diabetic macular edema. Dr. Vishali
Thank you.
Gupta.
Thank you, sir, for the very kind invite. So we have done lasers, we have done injections, we have done metabolic control. So now let's see how do we diagnose, you know. So the patient might come to you at very early stage, which is very early non-proliferative diabetic retinopathy. You have done your 90-day, 78, or whatever you do, and you see these changes. Honestly, no further imaging is required. As per the protocol, you can keep the patient under follow-up, but even if you decide 3-6 months follow-up, it's very important to endorse them to get their metabolic control, to get their lipids control, and more importantly, the nutritional anemia control, because nobody talks about that. The Indians do not have anemia related to erythropoietin, they have nutritional deficiency. So it's important to look at that iron and vitamin D as well. You may go on to somewhere more, you are seeing here more hard exudates, more this thing, and you feel that, well, it's mild to moderate diabetic, nothing to be done, like I said. But before you jump on to that conclusion, you have to be very clear that there is no macular edema. So how do you make sure of macular edema? For the comprehensive ophthalmologist who probably do not use stereopsis, there are monoocular clues. Like you see some grayish things in the center, you see the hard exudates. The moment you see the hard exudates sitting in the form of the circinate rings, there is going to be retinal thickening, whether you have OCT or whether you have stereoptic visions or not, but you assume and you think that there is macular edema. If you are not sure, it's good to do OCT, and for a comprehensive, when you do OCT, you have to categorize it into two very simple categories. Look at the line scan through the fovea. So you have the macular edema, which is involving the center of the fovea, and fovea is elevated. Now, these are the kind of the patients who would require anti-VEGF injection. The second kind is the macular edema, which is not really involving the fovea, which is away from the fovea. Now, these are the kind of the patients where you might consider laser. But be mindful of the fact, looking at the OCT map, the thickness has to be more than 300 or 350 micron before you jump on to starting any kind of treatment. There have been a lot of discussion about the patterns that you see on OCT. We do not have a real strong evidence that you manage them, but in practice, all of us do look at the pattern. This is the mildest form, the sponge-like thickness. Many a times you might see cystoid macular edema, and to me that is important because cystoid macular edema, I will not push in the laser. I will try to bring down the thickness by anti-VEGF, steroids. That's a different topic, but I would like these cysts to go down before you actually think you want to do something more. Sometimes you may have a serous detachment like this sitting out there. Important to rule out proteinuria in such patients and the role of newer semiglutides, pioglitazones, because like Dr. Babu said that we have to do a stringent control. But many of these newer drugs which are doing stringent control are causing macular edema as well. So you have to be very mindful of the fact that before you start jumping your guns at whatever you want to inject, make sure what therapy patient is receiving. And the most important is the traction. If you see traction on the fovea, this is a tractional variety of macular edema where neither the injections nor the laser will work. So if we have to do something, it is mostly surgery. Surgery brings about the anatomical results, but the long-term meta-analysis have shown that the vision does not do remarkably well. So let's go on to the next. The next component was a non-center involving. So if at all you are planning laser, do a good fluorescein angiogram, identify the microaneurysms which you have to, and Ajay has already told you all about that. Moving on to more severe form, you will see more soft exudates, which are nerve fiber layer infarcts caused by the occlusion of the peripapillary arterioles. You may see these loops and beading. Now, don't take these beads and loops lightly, because these are the areas where you would invariably see large areas of capillary non-perfusion sitting next to loops and beads. So if you have wide field or if you have fluorescein, please go ahead and do it. Even if you don't have, it gives you a good clue that there is a lot of ischemia happening which needs to be taken care of. ETDRS did find that ARMAs, hemorrhages, venous beading and loop, CNP, and widespread leak on fluorescein are actually the risk factor for development of PDR, not multiple cotton wool spots. So NPDR goes on to the more advanced form, and you see more and more of these lesions. Now, if you are seeing a retina like this, which is ischemic, be very careful of labeling it as NPDR, because 50% of them are going to bleed over a period of 1 year. So if you have seen this patient, missed some fine new vessels, ask the patient to come on follow-up after 6 months, patient might end up like this. So even if you're advising the patients, please tell them to report to you at the earliest onset of floaters, because floaters are one of the very important early signs of a vitreous bleed. Coming on to proliferative, which is straightforward. If the new vessels are on the disc, you see them as mishmash, fine capillary network, and never let this patient walk out of your clinic without treatment, because new vessels bleed straight away into the vitreous. There is no barrier, there is no hyaloid there. So find new naked vessels on the disc, you have to take care. Don't wait for the angiograms. It doesn't give any more information. At the end, you have to inject and follow it up with PRP. This is how the NVD will bleed, and you can see the blood trickling into the vitreous, whereas NVEs are kind of more, you have some time to buy for NVEs, but NVDs you have to treat straight away. As PDR progresses, you get more and more of fibrous tissue, prominent tissue. So this is very simple. You look at the clinical exam and you know there is tractional RD because it is concave. But the moment you see some amount of convexity, take it as a combined RD, because the indication of surgery would be different for tractional than for the combined RD. The tractional RD we treat only if it is involving or threatening the fovea, whereas the moment there is a convexity, even if you are not able to see a hole most of the time because it is hidden under the fibrous tissue, this is an indication for surgery. Contracting vitreous is going to put on the optic disc, causing traction, and this is what is classically called tabletop traction of diabetic macular, of diabetes. So I have already told that there will be a tractional component which is concave, and then there is convexity, which means there is a rhegmatogenous component. So in conclusion, before you jump on to injecting laser or anything, it's very important to characterize diabetic retinopathy, and that characterization is mostly based on clinical exam. Thank you very much once again.
Yeah, Vishali.
Thank you.
Can
I
I
want
make
to
a
ask one
comment?
question.
Can I make a comment, small comment?
Yeah, please.
So as Dr. Vishali pointed out, it's very important to take the history before starting any treatment. So I recently had a case in which the patient complained of sudden decrease of vision, and in both the eyes together. And when I saw the patient did an OCT, she had those cystoid macular edema. So I thought like it is part of the diabetic retinopathy, and so I injected at that. But the patient did not respond to that. And then we took the history, why there was such a sudden in both the eyes. So she gave that her diabetologist had switched her to a newer drug called sitagliptin.
Yeah, semaglutide.
Yeah, and then we just saw one or two reports were there that this drug also causes macular edema. You just stop the drug and the macular edema reduces. So I think another important thing is a drug history also we have to
That is
ask the
India's
patient.
answer to
Already we have
Ozempic.
discussed, Sangeet, we have discussed
Okay,
that.
thanks.
Okay, see, you have given a lot of GPs are there, I mean general ophthalmologists are there, and beautiful angiographs. And OCT angio, a little bit, she's also skeptical about OCT angio. OCT, beautiful OCTs. Can you suggest to them which cases they should go for it quickly so that they can selectively
Go for OCT.
OCT and FFA?
If you are seeing NPDR, which you are very sure is very early, and the macula is appearing what my PGs call dull foveal reflex. I don't know what that means. Always do OCT to rule out macular edema. That is one thing. The second is you are seeing featureless kind of retina. The patient does not look very good. It's a kind of bit sick diabetic patient. The retina does not have the normal redness to it. And you are not sure it is NPDR or not because you are not finding the new vessels, but something looks off. Get an angiogram done. It may be ischemic retina, which is featureless. Thirdly, you have seen some INV or you are in doubt, but you are not seeing any new vessels in the back. Always get the angiogram done for some of these eyes. But if you are seeing the new vessels, you are seeing NVD, NVE, there is no need to do any angiogram.
So markedly asymmetrical DR also is another thing.
Asymmetrical DR, in addition to angio or OCT, I would suggest systemic workup, very important.
Carotids. Just
Especially
stand behind the
carotid,
patient and pass the
myopia,
carotids.
trauma, and sleep apnea.
One of the factors that I didn't mention is about the sleep apnea. That's another very important factor that you have to check with the patient whether he has a history of sleep apnea, because that can worsen the diabetic retinopathy.
Snoring. Yeah.
Yeah. Thank you, Vishali.